Today we are going to be looking at retroperitoneum, and this is the image that shows the internal organs of the abdomen. The retroperitoneum has to do with the spaces behind the peritoneum that encapsulize all these organs. These are what we are going to be talking about and more. But before we begin, please, I want you to like, share, subscribe, and put on notification to receive all our free lectures. For more information about our paid classes, please send me an email to sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019 144 175, or visit our online store at sonoeyes.business.site. Attend the quiz in the description and leave me a comment. Let's begin. Now, the retroperitoneum is the anatomical compartment that is enclosed by the peritoneum anteriorly, the transversalis fascia posteriorly. Superiorly, it extends up to the diaphragm, and inferiorly up to the level of the pelvic brim. Transversely, it spans the width of the abdomen. The retroperitoneum has two large divisions, that is the lumbar fossa and the iliac fossa. Now, when you remove the anterior compartment of the abdomen, the organs in the anterior compartment, this image shows you what will be left. And these organs are the organs that are basically at the posterior, at the retroperitoneum. You find the kidney and the adrenal gland with the large vessels with it. Then you have the green portion of this image, retroperitoneum, that is the ascending colon, descending colon, then a portion of the sigmoid colon. Now let's look at the iliac fossa. This fossa lies below the level of the iliac crest. Often we call it the false pelvis. This is a potential space which lies between the posterior parietal peritoneum and the iliac fossa. It contains portions of the ascending colon, the descending colon, the ureters, and the common iliac vessels with their associate lymph nodes. It's a frequent site for renal transplantation. And now these are the organs you can, the structures you can find within the iliac fossa as described. While the lumbar fossa lies above the level of the iliac crest, within the lumbar fossa, the retroperitoneum is further divided into three spaces: the anterior pararenal space, the perirenal space, and the posterior pararenal space. And this image shows you the organs that were found in the lumbar fossa and the vessels. And let's look at the anterior pararenal space. This space lies between the peritoneum anteriorly and anterior pararenal fascia, or what you call the Garutas fascia posteriorly, and the lateral conal fascia laterally. This space contains the ascending colon, most of the duodenum, the pancreas, the descending colon, and large amount of fat and fibrous connective tissue, like you see in this diagram. The areas yellow is the perirenal space, which is encapsulated with the Garuta fascia that forms the posterior surface of the anterior pararenal space. Okay, posterior pararenal space lies between the posterior pararenal fascia or the aorta fascia anteriorly, and the posterior or the transversalis fascia posteriorly. The transversalis fascia is the membrane that covers the peritoneal surface of the transversus abdominis muscle and its aponeurosis. The right and left posterior pararenal spaces are separated posterior-medially by fusion of their fascia with that of the fascia of the paraspinal muscle. The posterior pararenal spaces continue laterally and anteriorly as the abdominal wall fat extends to the peritoneum. Now, each posterior pararenal space contains mostly fat. As you see, posterior pararenal space that is shaded with the purple color. Now, the perirenal space lies between the anterior pararenal and the posterior pararenal spaces. Anteriorly, it is bounded by the anterior pararenal fascia or the aorta fascia, and posteriorly by posterior pararenal fascia, which is also the aorta fascia. They contain kidney, adrenal glands, and abundant perirenal fat. The left and right pararenal spaces are separated from each other by centrally located great vessels, that's the IVC and the aorta, wrapped in their connective tissue sheets. The perirenal area is often superior on the right to the bare area of the liver, allowing communication between the retroperitoneum and the intraperitoneal spaces. Like you see in this diagram, the yellow areas and is actually fat, then other appendage structures. Now, this table discusses the boundaries and the content of the anatomical spaces of the retroperitoneum. You take some time to look at them and understand what we just explained. Now, the importance of understanding the facial layers or the spaces in the peritoneum, because you know the knowledge of the facial layers of the peritoneum is essentially in understanding the pattern of spread and containment of pathological processes. Now, these facial layers are rarely directly visualized by sonography. Their presence can be inferred by the demonstration of a collection or other pathological processes conforming to the known compartment. Now, the tissues dividing the peritoneal space determine where the abscess and fluid will spread and collect. Now, all three retroperitoneal spaces communicate inferiorly. It is possible for anterior pararenal space fluid to migrate into the posterior pararenal space fluid by inferior routes without involving the intervening perirenal space, like you see in this image. So, like in the drawing on the left, this drawing illustrates the traditional tri-compartmental model of the retroperitoneum, which we described, and the drawing on the right illustrates the recently modified tri-compartment model, which reflects the understanding of the perirenal fascia and the lamina and the variable fusion that occurs with the interfacial connections and their spaces. So, retrofacial muscles, these are located posterior to the posterior pararenal space and are separated from this space by the transversalis fascia. So, it is incorrect to refer to them as retroperitoneal muscle even though they are located posterior to the retroperitoneum. Skeletal muscle fiber are grouped into bundles defined by adipose septa. Dense connective tissue covers the entire muscle, and additional thick fascia separates individual muscle. And this is a sketch diagram for the posterior abdominal wall muscle. Sonographically, on longitudinal scan, muscles appear hypoechoic with the septations seen as oblique fine echogenic strands. On transverse scan, the septa have this punctate or linear appearance and are scattered throughout the hypoechoic background of the muscle. The symmetry is important in assessing these bilateral muscle, as pathology may cause unilateral hypertrophy or atrophy. So scanning through contraction and relaxation of the muscle may help detect abnormalities. So let's look at some of them. For example, quadratus lumborum muscle. This muscle originates from the lower border of the 12th rib and transverse process of the lumbar vertebrae. They insert into the iliac crest. On ultrasound, they are seen posterolateral to the psoas major muscles and posterior to the kidney. They are hypoechoic, bilaterally symmetrical, and can be mistaken for masses of fluid collection if the machine setting are incorrect or in large patients due to beam attenuation. And this is an image of the quadratus lumborum and the origin and insertions. And this is an ultrasound image of the quadratus lumborum. You see that triangular appearance. Other muscles are psoas major muscles. Now these are long fan shaped muscles that originates from the side of the lower thoracic and lumbar vertebrae. They insert via tendon, which joins the tendon from the iliacus muscle into the lateral trochanter of the femur. On ultrasound, these muscles appear as hypoechoic structure lateral to the lumbar vertebrae. The medial border of the kidney rests against the lateral border of the psoas muscle. And this is an image to show the psoas muscle and other associate muscle. And on ultrasound, this shows the psoas major muscle as it relates with other muscle, quadratus lumborum, intraperitoneal spaces, and so on. Now, the iliacus muscle arises from the iliac fossa and joins with the psoas major muscle to form the iliopsoas muscle. On ultrasound, they appear as hypoechoic structure lateral to the spine and bowel and inferior to the iliac crest. The bright curvilinear echo of the iliac wing is posterior to each iliacus muscle. Iliopsoas muscle. Now, this is the name given to the compound muscle that is formed by psoas major and the iliacus muscle on both sides. On ultrasound, the hypoechoic iliopsoas muscle is parallel to the common iliac vessel. The caudal portion of the iliopsoas muscle have an echogenic central tendon. In the pelvic area, these appear as small oval structure anterolateral to the field bladder and are readily identifiable by central echogenicity in female, often mistaken as ovaries. And this is an image to show the psoas major and the iliacus. That is iliopsoas combined. Let's talk about the retroperitoneal fluid collection. Now, the most common fluid containing masses in retroperitoneum are abscess, hematoma, seroma, urinoma, and pancreatic pseudocysts. Unlike loculated intraperitoneum collection, these abnormalities in the retroperitoneum are more difficult to distinguish by ultrasound alone. Fine needle biopsies are usually required for a definitive diagnosis. Ultrasound guidance is invaluable for directing needle placement for both diagnosis and therapy. The most effective boundary to the spread of fluid in the retroperitoneum is the renal fascia, loose arrangement of fat and connective tissue that surrounds the kidney and adrenal gland, and they separate the perirenal spaces from the pararenal spaces. The renal fascia usually prevents fluid from crossing the midline. Now, posterior pararenal collection tends to displace the kidney anteriorly, and anterior pararenal collection produces renal compression. Perirenal collection tends to occupy more than one surface of the kidney. In other words, it's all around the surfaces of the kidney. Hematomas generally occur in association with leaking aortic aneurysm following trauma, or it could be iatrogenic during catheterization. May also occur in patients with anticoagulant therapy or in hemophiliacs. Common sites of hemorrhage include the perinephric spaces and the psoas muscle. Hemorrhage into the psoas muscle causes unilateral diffuse enlargement, which may push the kidney forward and may cause the muscle to appear diffusely hypoechoic. And this is an image to give an idea of what retroperitoneum blood will look like. On ultrasound, findings are basically non-specific due to spectrum of sonographic appearance associated with the age of the hematoma, ranging from anechoic to echogenic, followed by mixed echogenicity, then hypoechoic again. So less than 6 hours, hematoma will appear anechoic. From 24 to 72 hours, hematoma will be appearing echogenic, and moving forward, it will appear mixed echogenic, then hypoechoic. The clinical history and a drop in hemoglobin and hematocrit values will confirm the diagnosis. And this is an image to show hematoma, and we have a CT image to show the location of the hematoma. Very valuable images to understand what we just discussed. Now, these images show ruptured aneurysm of the abdominal aorta with large retroperitoneal hematoma causing displacement of the right kidney, and below you have abdominal aorta with defect in anterior wall of the aorta and a large hematoma that is formed there. Seromas. Seroma is a tumor-like mass caused by collection of serum. Serum is this liquid blood plasma that is not containing cells and clot protein. Yeah. So on ultrasound, seromas appear anechoic and difficult to distinguish from other anechoic fluid collection. However, like lymphocyte, they are also more associated with renal transplant and pelvic surgery. Abscess. Retroperitoneal abscesses are commonly results of direct spread from renal, spinal, or intraperitoneal infections. They may occur secondary to an existing fluid collection, such as lymphocyte, hematoma, urinomas, or pseudocysts, and may also frequently occur post-operatively. On ultrasound, sonographically, abscesses have variable appearance and may be solid, maybe mixture, or anechoic, and are generally they show through transmission, most importantly. Gas-forming organisms produce bright linear echoes with posterior dirty shadow or ring-down artifact. It's also a very valuable feature to say this is an abscess. And this is an image, ultrasound image to show an abscess, retroperitoneal abscess. Lymphocytes, these are cystic collection of lymphatic fluid as a result of surgical or traumatic disruptions of the lymphatic vessels. They're commonly seen after renal transplantation. You also will see that in lymphadenectomy in the retroperitoneum or pelvis. They usually develop after a month or two of surgery. Some small lymphatic vessels remain open, and over a period of time they form this fluid mass. In time, these vessels will anastomose and the fluid collection will be reabsorbed. But sonographically, most lymphocytes are anechoic cystic masses or anechoic loculated fluid collection located near the surgical site. Internal debris and septations may be seen and are indicators of hemorrhage or infection. Leg swelling on the same side will suggest lymphocyte. Urinomas, a collection of urine commonly localized in the perirenal region. Usually they will result from trauma, interventional procedures, or high-grade acute ureteral obstruction. Also occurs as early complications of renal transplant. Sonographically, urinomas are usually anechoic and well-defined cystic masses, and they may show septations. And this is an example of urinoma, and you can see the kidney, the right kidney is showing signs of hydronephrosis. Let's look at pancreatic pseudocysts. Now, pancreatitis may result in the rupture of pancreatic gland with liberation of pancreatic enzymes into the anterior pararenal spaces. These enzymes may digest surrounding tissues and blood vessel walls and will form free uncapsulated fluid collection around the peripancreatic region. Later, often after 6 weeks, a distinct wall encapsulates the fluid, forming a cystic structure. This cystic structure lacks a true epithelial lining and is defined by organized fibrous tissue that borders around it, and that's why it's called false cyst or pseudocyst. And this is an example of pseudocyst on ultrasound and in a drawing. While free pancreatic fluid collection, that is the uncapsulated pancreatic fluid collection, are commonly located in the peripancreatic region in the lesser sac. You find that in lesser sac, perirenal spaces, pericholecystic region, Morrison's pouch, splenic hilum, right and left paracolic gutters within small bowel mesentery and in the pelvis. Pancreatic fluid collections may give rise to pancreatitis ascites. Small free fluid collection or small loculated collections may resolve spontaneously. That is, small pseudocysts may resolve spontaneously. However, larger ones may require surgical decompression or catheter drainage. Sonographically, pancreatic fluid collections are anechoic areas without well-defined margins around the peripancreatic region. In the lesser sac, in the perirenal spaces, in the pericholecystic region, Morrison's pouch, splenic hilum, right and left paracolic gutters within the small bowel mesentery and in the pelvis. Pancreatic fluid collection may compress or may erode the surrounding vessel wall, especially the splenic vein, the superior mesenteric artery, and IVC, resulting to thrombosis within the veins and eventually portal hypertension and hemorrhage. Pancreatic fluid collection may also erode the bowel wall, producing GIT hemorrhage, rupture, and peritonitis. And this is fatal. Pancreatic pseudocysts are initially well-defined anechoic fluid collection with measurable thick wall. When absorption process starts, they may show internal echoes, septations, and calcification with or without posterior acoustic shadowing. Large pancreatic pseudocysts may compress the stomach and result in gastric outlet obstruction. Now, this is an example of encapsulated pancreatic fluid on ultrasound and in drawing. Now, let's quickly talk about retroperitoneal masses. You have the benign retroperitoneal masses. These are non-neoplastic. You have the retroperitoneal fibrosis, retroperitoneal lymphadenopathy, retroperitoneal abscess, retroperitoneal lymphocyte, retroperitoneal urinoma, retroperitoneal hematoma. Benign neoplasm of retroperitoneum include fibroma, lipoma, mesothelioma, myxoma, and teratoma. Malignant neoplasm of the retroperitoneum includes fibrosarcoma, leiomyosarcoma, liposarcoma, and rhabdomyosarcoma. A quick look at the benign retroperitoneal masses. Retroperitoneal fibrosis. This represents dense fibrous tissue proliferation in the form of plug-like or bulky mass, 2 to 6 centimeter thick, and is confined to the anterior surface of the abdominal aorta, IVC, or psoas muscle. They extend from the perirenal space between the hilar of the kidney to the dome of the bladder, and is characteristically encases the abdominal aorta, IVC, and ureters. It is a progressive disease resulting in narrowing of the retroperitoneal vessels, which are the aorta and the IVC, alongside with the ureter. Urethral obstruction may progress to hydronephrosis and renal failure. So it's important to pay attention to patient history and understand the retroperitoneal spaces and pathology occurring in those areas. Causes of RF, 60% of the time we don't know exactly what the cause is. Well, 88% of the time could be associated with infiltrating neoplasm. 12% of the time it could be as a result of methylcellulose injection as a treatment for migraine. Less commonly associated with Crohn's disease or ulcerative colitis and with abdominal aortic aneurysm. In some patients, it is thought to result from an organized hematoma is associated with chronic slow leaking of blood from aortic aneurysm. So retroperitoneum fibrosis presents with ill-defined low back pain. Usually respond to medical therapy using steroids. Sonographically, is seen as the hypoechoic bulky mass with smooth, well-demonstrated anterior and posterior margins, characteristically encasing the abdominal aorta, IVC, and ureters. Medical displacement of the ureters is a characteristic of retroperitoneal fibrosis. Visualization of the retroperitoneal area is facilitated by the use of graded compression sonography, which improves the image quality by displacing overlying bowel gases and reducing the distance between the transducer and the targeted structure, allowing them to fall within focal zone and the transducer. Color Doppler evaluation is helpful to identify aorta and IVC within the mantle of dense fibrous tissue. Differential diagnosis, it is sonographically similar to retroperitoneal sarcoma, hematoma, lymphomas, and midline portion of the horseshoe kidney. Lymphadenopathy generally appears more lobulated, and these images from ultrasound and CT to give you an idea of retroperitoneal fibrosis, or you can also call it the Oman's disease. Yeah, that is more information from ultrasound and CT. On CT, you can see the narrowing of the IVC at the point of bifurcation. So, retroperitoneal lymphadenopathy, lymph nodes are virtually aortic, para-aortic, retro-aortic, or retrocaval nodes that surrounds the aorta, IVC, and anterior to the spine. Normal size retroperitoneal lymph nodes will be up to 1 centimeter in diameter and are usually not seen by ultrasound. Solitary nodes greater than 10 mm are usually seen and considered enlarged. Multiple lymph nodes that are larger than 6 mm are considered enlarged. Note that normal superficial nodes, example like cervical nodes, can be demonstrated by high-frequency transducer used for superficial parts scanning. So ultrasound is 80 to 90% accurate in demonstrating enlarged nodes, and it is quick and inexpensive. CT is having a greater than 90% accuracy in demonstrating all major nodal areas, but yet cannot show the internal structures of the nodes. Lymphangiography can demonstrate the internal architecture, but more invasively. So this is an example sonographic image of retroperitoneal lymph nodes. In Hodgkin's disease, you have enlarged retroperitoneal mesenteric nodes. Then the image below shows sclerosing liposarcoma and fibrous histiocytoma and vena cava thrombosis. Retroperitoneal lymphadenopathy is most commonly seen in lymphoma, that's 25%, with Hodgkin's disease, 50% with non-Hodgkin's lymphoma. Metastatic spread from primary cancer located elsewhere in the body, most commonly from the testicle and pelvic cancer. Ultrasound is used to detect, characterize, and measure enlarged retroperitoneal nodes. So, sonographically, retroperitoneal nodes appear as discrete, homogeneously hypoechoic or anechoic solid masses that are located anterior and posterior to the great vessels. These masses may show some degree of posterior acoustic enhancement. A group of nodes may fuse to form hypoechoic solid lobulated masses encircling the aorta and often distorting or displacing the aorta and its branches. Color Doppler is helpful to identify the displaced aorta and IVC quickly within the mantle of nodal tissue. And this is an example of retroperitoneal lymphadenopathy from primary cancer of the stomach, distorting and displacing the aorta and its branches. Primary retroperitoneal tumors, benign and malignant neoplasm. Now, any tissue in retroperitoneum can give rise to benign or malignant lesion, though these are rare. However, most lesions arising from the retroperitoneum are malignant. Benign neoplastic retroperitoneum lesions are commonly either lipomas arising from fatty tissues or leiomyomas arising from smooth muscles. Other benign neoplasm include fibroma, mesothelioma, myxoma, teratoma. Malignant versions of these tumors are liposarcoma, leiomyosarcoma, fibrosarcoma, rhabdomyosarcoma, respectively. On ultrasound, the features of the retroperitoneal tumors are non-specific. The malignant lesion may present as a complex or centrally necrotic mass or as a homogeneous soft tissue mass of increased or decreased echogenicity, like you will see in this image of ultrasound and CT. You can see retroperitoneal sarcoma with central necrosis on ultrasound, and on CT you can see the retroperitoneal sarcoma. I want to thank you for joining this lecture. Please like, share, subscribe, and put on your notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019 144175, or visit our online store at sonoeyes.business.site. Attend the quiz in the description and leave me a comment. Until the next time when I come your way again, keep learning ultrasound.